Hello and welcome to the n-Lorem podcast series, the only podcast series that's devoted exclusively to the needs of patients with nano-rare mutations. I'm Stan Crook. I'm chairman and CEO and founder of n-Lorem, and I'm your host on the n-Lorem podcast series. And today we have a very special guest, a person I've gotten to know over the last year or so, who has lived in a part of the world that I understand very poorly, and I suspect most of you do too. And so I'm really looking forward to this chat and to sharing and having Alan share his leadership understanding of these parts of the healthcare system. Our special guest is Dr. Alan Lotvin. Alan is a cardiologist who practiced cardiology. Welcome, and then moved on to do many other things that are fascinating to me, and I think will be to you. So welcome, Alan.
Thank you, Stan. I'm really glad to be here. Really glad to get to know you and what you've done in both at Ionis and n-Lorem. And I continue as much as you can teach me, as much as I can teach you about the PBM industry. You can certainly teach me much more about ASOs and the scientific discovery process. So it's been great.
Well, it's been a happy marriage, and look forward to continuing to expand it. So I'm assuming, Alan, you grew up in the New York metropolitan area. I mean, since you
I did. I grew up. I like to say I was born in Manhattan, so I'm proud of that. My parents moved me to New Jersey and to Long Island, and as soon as I was sentient, I moved back to Manhattan. Went to medical school I moved back to New York. I went to medical school in Brooklyn. Did almost all of my training at Mount Sinai, and then lived in the New York area for a long time until I moved up to the Boston area, and 20-something years ago, and been loving it in Boston as well.
Yeah, and you actually practice cardiology in the New Jersey area, right?
I did. I was an interventional cardiologist, so stents and angioplasties and things like that. I worked out of a couple of hospitals, a little one in northern Manhattan called Columbia Presbyterian, and then what's now a huge one in New Jersey called Hackensack, which when I started there was not quite so huge, and they've done a very nice job of building a world-class medical center there.
Yeah, cool. And it is amazing to me the impact of endoscopic surgery on patients. And of course, as an interventional cardiologist, you were at the sort of forefront of all that. I just don't think people appreciate how profound the benefit of learning how to do surgery through a little tiny endoscope has impacted patients.
Yeah, and an interventional cardiology was sort of fascinating because it didn't. I think people originally thought about it as a replacement for open heart surgery, and what it really became was an augmentation. And if you look at the best indication for angioplasty or stent placement now, it's when you're in the middle of an acute heart attack. If you're in the middle of an acute heart attack, you absolutely positively want to get a revascularization procedure, and it makes a huge difference.
Yeah.
Whereas, bypass surgery tends to be kind of more treatment for symptomatic and creating longer term great outcomes. But they tend to be, synergistic procedures. And it was really fun doing it. Like when I was, people asked me, do you miss practice? And I miss a lot of aspects of taking care of patients and meeting people and like being invited to become this incredibly, intimate partner in their health. But I also missed, for a while, really missed doing procedures, because especially when I was doing it early on, like there was a technical aspect to it that was fun. You had to understand kind of the materials and how they would, fold in 3 dimensions in the aorta, and that kind of stuff was really, really, really fun. So yeah, I miss it a little bit, but like everything else, you close one sort of set of fun things to do, and you learn a whole nother set of fun things to do.
Yeah, and you did. And that brings us to specialty pharmacies. I really am intrigued by how a nice, successful cardiologist should stumble into being head of a specialty pharmacy outfit.
So it's a great question, and you used a really good word, which was stumble in, and you know, as the progression was, I realized in 1997 that despite our eagerness around revascularization procedures and coronary revascularization, that it wasn't the panacea we thought it was. Again, if you're having a heart attack, it's perfect, but almost every other scenario the procedures don't seem to have very much impact. And I really struggled with how to maintain a referral practice. And I had a pretty big referral practice and not do something that I wasn't really 100% sure was the best thing to do. And so I ultimately decided that I was going to leave practice. And it was kind of shocking to my partners at the time, as
I
well as
bet.
my colleagues, and I often credit my wife like being totally supportive and saying, sure. And so at that time, I was really interested in what we now call big data or we called for a while big data and population health management. And Merck happened to literally had an ad in the New England Journal for someone to do this kind of work in cardiology. I'm like, you know what? It's Merck. I know them, respectable, organization in my backyard. Don't have to move. If I hate it, I can always go back into practice. And so I joined there, and what I learned was I was actually joining a subsidiary of Merck called Medco, and Medco is a pharmacy benefit manager. And I learned about what PBMs do, and I know we'll talk about it. Like one thing that struck me as really interesting was they had this huge amount of data. At that time, it was, I don't know, 30 million people in the US. It was almost real-time data. And I thought it was really clinically relevant data in the sense that it reflected what was actually going into the body versus what someone wanted to get paid for. And I thought this is really cool, and we can do a lot of work here and a lot of good things in terms of closing the gaps in care, highlighting for patients and doctors, because we had a unique view in this world. We would see every prescription no matter where it was filled. And so we got to see and learn all sorts of things, like uh, how bad adherence and compliance and persistence is. Like people don't keep taking their drugs long term. And we looked one time, this was again going back 20 something years, but we looked at HIV meds, statins, and imatinib. So for leukemia. So 2 out of 3 drugs that were absolutely life preserving. And we said, which one are people more likely to drop off of? And it turned out that it wasn't much of a difference. At 2 years, only about 60% of people were taking any one of those.
Yeah.
And obviously especially at that time, very different patient populations. And that was really instructive to me. And, you know, learned a lot about why people don't take drugs, and it's not simple and there's no single answer. So that's how I got into the PBM industry. And after about a year or so, I realized I really liked it. And it was a place where you could see the ability to reduce the cost of care. You could see kind of a little bit of the future of what drug therapy looked like, and it seemed to be an interesting place to be. So I stayed there. I did a couple of you looked around the organization. Everyone who was in charge and senior, they all had experience with clients. So I raised my hand and said, "Hey, I'd like to get some client experience." They said, "Why don't you go be the chief medical officer for this new division we're building to manage United Health Group?" I asked my wife if we could move to Minnesota. She said, sure. My wife's fantastic, right? So we moved to Minnesota, and they offered me the job, and I tell this story to everyone, and it was great, except for it kind of didn't feel like it was a real job. So I asked the guy who gave me the job, a guy named Glenn Taylor, who I am eternally grateful to. I said, Glenn, this is great. Can I have a real job too? And for reasons unbeknownst to me, Glenn gave me a $7 billion P&L to run. And that was sort of the transition into the business world. I did well at it, did another job, and then Medco got spun out and they needed to build a specialty pharmacy. So what's a specialty pharmacy? Specialty pharmacy is and was specifically for drugs that were expensive, $10,000 to $1 million a year, usually had cold chain requirements, which traditional pharmaceuticals, pills, tablets, and capsules didn't need, often had some some incremental clinical requirements, whether it was a REMS program imposed by the Food and Drug Administration, or other data needs that the manufacturers would put on. And so you'd form and often the manufacturers would limit distribution because they wanted really close control over the drug in these patients. And at that time, it was only about 1% of the drug spend. One of the drugs that was sort of commoner was a big one then, was epoprostenol for pulmonary arterial hypertension, kind of a continuous infusion, needed a pump, it needed all sorts of support. And so we built these pharmacies to meet the needs of those patients. And what happened was, over time, with the wave of antibody therapies, all of a sudden the cold chain requirements, all of those things, it went from being 1% of drug spend to being 54% when I left of drug spend. And people would say to me, Alan, how did you know like specialty pharmacy was going to grow so much? And if I'm being obnoxious, I say it's because I'm brilliant. And if I'm telling the truth, I say it was a hard problem that the company needed solving, and I was the right person to do it. Now, I was smart enough to realize that this was going to be a good wave to ride. And so I helped build, two of the largest specialty pharmacies in the country, and we really sort of thought about how do we make the experience better for patients, how do we lower the costs, how do we help on the compliance and persistence side, so that if you're going to spend thousands of dollars a month on a product, you don't want the person to drop off it before the clinical benefit appears. And so that's how I got into specialty pharmacy. And I pretty much stayed in specialty from 2001 or 2 to about 2017. I had a couple of detours. Some of it was I was focusing on oncology and the drugs that are paid under the medical benefit versus the pharmacy benefit, but generally all of it was in specialty, really until I took over Caremark as a PBM. But there was a long story about my history, so I apologize. Feel free to edit it, basically.
No, actually, you said a whole bunch of really important things that I want to parse. First of all, you talked about compliance and focusing on Lipitor, for example, or statins. These are close to perfect drugs in that the side effect profile is de minimis. They're easy to take. Once a day does the job. Anytime you take it is okay. And the evidence is overwhelming that taking it, probably everybody should take it all their lives, no matter what, right? I mean, and yet, as you said, 2 years out, people are not taking their drugs. And this continues to be a core challenge in therapeutics. And in AIDS and cancer and whatnot, you can understand some of it because, at least in those early days, there's a lot of side effects, and there's still a lot of side effects. And you could imagine people dropping out. But when you take a statin and ask why people stop, so I've spent a lot of time looking at that. I'm interested, if you had to pick the top 3 reasons people stop taking statins, what would it be?
So well, I'll give you the 3 reasons, but I think there's also something else that's not really talked about that much, which is I'm not sure that we actually offer statins as broadly as we should. I have a lot of friends and neighbors who will tell me, my cholesterol is whatever, and my doctor said that, he's not ready to start statins yet. And my perspective, for what it's worth, is you can't really have an LDL that's too low. And the lower you have the LDL, for the longer you have a low LDL, the less atherosclerotic heart disease you're going to get. And it's still the #1 killer in the world, and it still contributes to the #3 killer, which is dementia. So why wouldn't, to your point, there's such safe drugs, why wouldn't you want to have your LDL, below 70 all the time, or lower? And so I'm probably way out on the scale there. But to answer your question, what are the top 3 reasons? So we did some work, And it really turned out we had this, we found some academic work that there were 17 barriers to why people don't take drugs. Um, and we looked at it in our population. And again, it's a skewed population when you look at PBM data because it is by definition insured people. So in general, insurance wasn't the biggest issue, but the copay was. So there was a financial aspect, and it's particularly gotten bigger as the list price of drugs has gone up and the prevalence of high deductible plans have gone up. So we'll lump in like economic barriers are absolutely one of the barriers. That's usually a barrier to starting therapy. It's not as much a barrier to continuing therapy. I think the other big barrier to people in continuation of therapy, it's not that they forget, despite all the gadgets and gizmos, people they're not forgetting. Yeah, may forget a dose a week or so, but you're not forgetting reliably. I think there's a lot of it is that whenever you feel anything that's not normal and you're taking a drug, the impulse is to ascribe it to the drug. And so, I'm taking a statin and my vision was blurry. Well, okay, it's a statin. I stopped taking the statin.
Or
Or
I had a muscle ache.
I had a muscle ache, and I heard you can, have bad for your muscles. It could be anything. So that's the second big one. The third big one that I think is really, 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 really under discussed, and there's probably because it's not an easy answer, is people don't like to feel like they're sick, right? They don't want to feel like they need to take a drug because it makes them feel like they're sick or they're getting old and often there's someone else they know, who said, "Oh, I had X disease and I took, some miracle vitamin and some, algal extract and I danced under the light of a midnight sun and I was cured." And of course that's not happening, right? But it's like, oh, if that worked for my neighbor, and sometimes it's not that egregious, right? It could be that, the neighbor had, I'll give you an example. It's obvious, like the neighbor might have been diagnosed as pre-diabetic and lost 60 pounds. And so now he's no longer diabetic. So I get diagnosed as pre-diabetic, my neighbor's not, and the neighbor says, "Oh, I just changed my diet and I stopped eating, whatever, and it went away," not realizing it was the weight loss that really did it. And so there's that's I think the biggest issue. People don't want to feel like they're sick, and so the combination of ascribing every ache, pain, symptom to the drug and really not wanting to take drugs is really um, the biggest issues, are the biggest issues.
That's fascinating. And and focusing on statins, if the future of medicine is preventing disease, which it is, I think everyone who knows anything about where we are in health feels we should focus on health more and disease less. Then getting people to take medicine, despite the fact that they don't have symptoms, is going to be one of the central challenges of the future, right? And I wonder how you would respond to also just the possibility that people are much more willing to intervene with themselves if they're feeling something than they are if they're worried about what they might feel 20 years down the road.
So I think that's true. I think there's three things. And by the way, I always think there's three things for everything, but I think there's three things that go into that. So one is that people, yeah, absolutely, prevention is hard, especially when all the other things we talked about in terms of prescribing, products. The second is, I think, and with all due respect to doctors, we not only do we not teach doctors about prevention, there's this idea that, wait until something is at a certain point before you treat. Like, the great example is hemoglobin A1C for diabetes, right? If you're below 5.7 or below, you don't have diabetes. Above 5.7, you do. Now, I'm not a diabetes researcher, I'm not an expert, but I refuse to believe that in your body there is some discrete quantum leap in physiologic process that says, oh, at 5.7, I don't, but at 5.8 or 5.71, oh, now all the bad things happen. It's most likely like everything else. It's on some sort of
Gradient.
gradient, and it may not be linear. It may in fact be, a curve. But so that's an example where why wouldn't you want to be at 5 or 4.5, and especially if you can get there safely with statins. We talked about earlier. If you could get to if you had an LDL less than 70 from age 30 on, I don't think you'd ever get coronary disease ever.
Unless you have an ApoA that's elevated, maybe.
A great point. In the absence of the 30% of the population with ApoB, actually, elevated Apo. No, actually, I'm sorry. If we'd be really technically correct, it's LP little a, because ApoB you can lower with statins. LP little a you can't.
Well, we've got a drug called that is in an 8,000 patient week, Ionis, the first ApoA inhibitor, but that 8,000 patient study is finishing, and I think it will be the next major step forward.
Yeah, no, again, but if you looked at all of the different kind of comprehensive lipoprotein pattern, like we talked about, ApoA, ApoB, LDL, HDL, fractionated LDLs, and LP little a, you can create a scenario so that I can treat all of these things to a greater or lesser degree, get your LDL down below 50, right? You probably never develop coronary disease. Now, again, I'm not saying people should do that. The data is not there. I will tell you that that's what I shoot for myself, right? But that's me.
I don't know a single cardiologist who doesn't participate in my LDL is lower than your game.
Exactly. And it's like, but so my point is that there's generally, but among a lot of primary care doctors and a lot of specialists, there is a reluctance to start people on medication until some threshold is hit, because that's what the standards of care. And I understand all the medical legal reasons to do that and all the other reasons, which is why I don't advocate it for anyone else other than myself. I know I'm not going to sue myself. So,
Yeah. Well, and of course, then there is the misguided worry about cost, because if you worry about cost of a statin versus the impact of cardiovascular disease on cost, you've sort of worried about a mole when you have cancer of the body, right? So,
right. Well, and that's the third part of it, which you just hit on, is a lot of there is non-insurance coverage often for preventive therapy. And you can look like the poster child for that right now is Wegovy for weight loss, right? Or Ozempic for weight loss. There's no question that these drugs help lose weight. There's no question that obesity contributes to all sorts of diseases. But if you look at the way a lot of even, I won't even pick on the GLP-1s for a second. Let's look at bariatric surgery. Like, people would say you had to be above a certain BMI, body mass index, to be eligible for bariatric surgery. Well, what a ridiculous incentive. So if I'm just below the threshold, instead of losing weight, I should go gain weight, right?
actually, I know people who have done that, who deliberately gained weight so they could get bariatric surgery.
And I think with my sense is I have seen some, authorization criteria or coverage criteria for the GLP-1s that say we only cover it above a certain BMI. So then when people lose weight, they're no longer eligible for coverage. You can't pay for the drug. People can't afford it. They gain back the weight, and you get into this cycling thing. It's, when people say we have a sick care system and not a healthcare system, that's not an indictment of the US. That's the world, right? And we really haven't reconciled yet the fact that we actually have the ability to, at least for some diseases, to dramatically reduce your likelihood of developing them.
Or said in a more positive way, we have the ability to enhance health.
That's right.
As
And
opposed to
we're not good at doing it. We're just not. we're not good at like, and that's partly doctors' fault. Like, we got to take ownership here. Like, it takes 20 years to get things out into the clinic for people, out of the lab into the clinic for people to really
Mhm.
start using them, aggressively. And we have to sort of acknowledge that. And so there's a lot of things we can do,
Yeah.
which is why I got
So
into the whole field of looking for gaps in therapy, because I thought we could. Turns out it's a lot harder to get doctors to change their mind than I ever thought it would be.
it is. So specialty pharmacies then are pharmacies that handle hard to handle drugs and expensive
Yeah.
drugs, right?
Exactly. So they evolved to be, hard to handle drugs, drugs that had cold chain requirements, drugs that required additional data capture, drugs where it was felt that the patients needed a greater level of support, either to manage side effects or to avoid complications. So you'd have a scenario where you'd have a group of people, like pick something like, cystic fibrosis, right? So we had a service, I don't remember how many people, let's just make a number up, 2 or 3 thousand patients with cystic fibrosis who our care team would take care of. And that's pretty much, it's a good chunk of the number of people with cystic fibrosis in the country. Now, how often is someone with CF going to walk into your local pharmacy, and is your local pharmacy going to be holding a $250,000 vial of drug in stock? Of course not. So now you gotta make another trip to the pharmacy, you gotta schedule it. What we have found is that, people get better adherence, better compliance, still not perfect, but better through the specialty pharmacies.
I want to move to PBMs, but there's one other thing that I think it would be very instructive to talk about. Uh, One of the numerous ways I've made people angry over the years is that I've argued that the right model for marketing is REMS. That REMS is a requirement to focus on patients who need the drug and then managing them while they're on the drug. And and we've witnessed over the last few years an enormous growth in drug advertising on TV. I mean, it's constant, and it makes me crazy because those ads are designed to get more people on the drug rather than keep people taking the drug, which strikes me, one, it almost certain you get people who take the drug who shouldn't, and it's almost certain that you lose people who should take the drug. Um, and so I don't want to get on that soapbox, but um, one of the things that I think the world is wrestling with, our world, yours and mine, is what is it that we ought to do that's responsible with marketing drugs? And I've been arguing for a long time that our job should be to get the right people on the drug and keep them on the drug. And that's where money should be invested far more. I think your data argued very persuasively for that as well.
Yeah, no, I think again, I think if you look at the drop off, right, you get a prescription written, a certain number of people never pick it up from the drugstore or get it delivered to their house. By the time they're on their second fill, like, there's a big drop off between the first and second fill, and I think that's a lot of that is either the economic because the coupon ran out, or it's that what we talked about earlier, ascribing any side effect to the drug. And then sometimes there's real side effects. And then there's just a steady drop off. But, there's also the issue that we touched on, which is, I don't think, I know some of the data for high blood pressure, right? So less than half of people who really have high blood pressure have actually been diagnosed. And of the people who are treated, only half of them are treated to goal. Right. So there's another thing we haven't even talked about, which is you're on the drug, but you're either not on enough of it, you're not on the right drug, you're not on the right combinations of drugs. And this is the thing that like when I just talked about kind of big data and using large data sets, you know, back in the back in the day, because again, I'm of a certain age. Before highly active antiretroviral therapy for HIV was available in one pill, but we knew that you had to take triple drug therapy. I'd look in the drug database and I would always see thousands of people who were on one of three, two of three, or the wrong three. And you'd sit there and you'd pull your hair out because you're like I was a cardiologist, but these weren't in like these papers weren't published in esoteric, infectious disease journals. They were in the New England Journal of Medicine, and you just go crazy about it. So, like, I agree with you that if we could take the same amount of money we spend on TV advertising that certainly raises awareness, we could say over raises awareness, and focus on helping doctors actually be better at their jobs and understand, and what real I think I think the companies would be far better off. And then if you added on, all right, if I now invested a lot more money in keeping people on therapy or the same amount of money, the return is
Yep.
again, I only remember the famous line about advertising. I only know half of it worked. I just don't know which half. At least when you spend money on adherence, you can measure whether it worked or not.
You bet. No, I think you're right. Companies would be wealthier and they'd feel better about what they do as well. Um, so now on to PBMs, pharmacy benefit managers. Briefly, can you tell people what a pharmacy benefit manager does?
So your question that said briefly is a clear evidence of the triumph of hope over experience, since I haven't said anything. But I'll try to be brief. So the PBM industry grew up as an amalgamation of different parts of pharmacy, and really if you look at it as a business study, essentially the industry grew up looking at where there were excess profits or profits that could be reduced, right, by bringing alternatives. So companies started out initially as like half the companies started as claims processors, the other half started as mail service pharmacies, and on the theory that mailing something was less expensive than retail pharmacy. And those entities came together, and what would happen is they would negotiate on behalf of payers, meaning employers, the government agencies, or health plans, with initially retail pharmacies to lower the cost or the reimbursement to pharmacies, and they would use kind of the mail service alternative as essentially a cudgel, a way to do that. And that worked for a while, and it worked, and it worked well, and they built the infrastructure, kind of the claims processing infrastructure. So pharmacy is the only part of medicine now. When you walk into a pharmacy, you may not know how much it's going to cost before you walk in, but while you're there, you know what it costs. It's not like you go to a doctor's office or a hospital and you get a bill 6 weeks later and you go, oh, okay. At least you're told in real time what it costs. And so the PBM industry does all of that claims processing, and at this point it's 4 billion or something claims a year, and the turnaround time is microseconds, and so it's a logistic feed. So that was mail service pharmacy. Then someone had the bright idea to say, there's 4 different H2 blockers, Zantac, Pepcid. I bet this was before they were, over the counter. I wonder if we asked patients, to switch, would they? And I wonder if we went to the manufacturers and said, would you be willing to give us a discount if we got? And it turned out that people were, and that became the beginning of formulary and kind of the quote unquote boogeyman of rebates, right? So people were able to interchange medications. And I think it's a great example of competition, right? If you look at what happens to the list price of drugs when there's 1, 2, or 3 in the category, it kind of drifts down. By it gets to 5, it accelerates, and at 8, it just falls off, and then it goes generic, right? So that was the second thing. Then the third big business model really was kind of coincident with when Zocor, statins we were talking about, went off patent in 2006. The percentage of generic prescriptions went from 42% in 2006 to about 92% now.
Mm.
And while generic drugs are much more expensive now than they were then, they're still 90% of the cost, or 90% discount generally to branded drugs. And the PBMs did a lot to drive the adoption of generic drugs. Now, the skeptic would say, well, that's because they made money on it. Yes, that is true. And the part about the PBM model that people hate is the lack of transparency about how these companies make money. And I guess in the conceptual ideal world, people would like a PBM to go to an employer or a health plan and say, I'm going to pass through every single bit of discount, rebate, whatever, and you're going to pay me X dollars per claim. But that doesn't work for a couple of reasons. Number one, no one likes paying money out of pocket, right? If I save 90% instead of 92%, I'm okay with that, right? I didn't have to pay out of pocket. That's one thing. The second thing is, and I don't really hear people talk about this that often, is that if you're a health insurance plan and you actually are covered under insurance laws, that payment comes out of your administrative bucket, and that means it reduces your profitability. So like the incentives aren't aligned. So what's happened in the industry is there are these very sophisticated consultants who understand how the companies make money. And so each time the companies develop a new profit target to exploit, whether it's pharma, pharmacies, generics, they make a lot of money for a little bit, and then it gets competed away in order to win more business, and they have to look for the next increase in the next business model. The fourth business model was specialty, right? Was the idea that, all right, if I'm going to take care of all of your patients, and I'm going to take care of all your patients' needs, well, I have the largest specialty pharmacies. I'm going to make them bigger by contracting. I'm going to give you a better price if you let me fill all of your specialty pharmacy. And became a virtuous cycle because you got more patients, so you could provide better service, so you could get lower prices from the manufacturers, which allowed you to get more patients. So you ended up with a scenario where, two or three of the specialty pharmacies are now the largest, all owned by PBMs.
Yeah.
So in general, PBMs do three things, right? They process the claims and do the plumbing. They negotiate with pharmacies to lower the reimbursement to pharmacies. They negotiate with drug companies to lower the cost of drugs, and they create plan designs that meet whatever the objectives or try to meet whatever the objectives are of the payer. That's my best attempt at being concise.
That's very helpful. And CVS Caremark was one of the largest, and you built it. You were CEO, and you.
Well, I'll be fair. It was the largest, but I can't claim credit for it. I credit where credit is due. In 2007 or so, CVS bought Caremark. They were 50% smaller than Express Scripts, which had recently bought Medco, and a guy named Per Lofberg, who was my mentor and just a fantastic man, joined the company and really drove the growth of CVS Caremark, and then his successor, John Roberts. And then I was at the end of a long chain of very, very successful people. I like to feel like I built on top of what they did, like the expression is truly standing on their shoulders. But we were able to bring a different service, different level of compliance, conformance, and what our customers were looking for, and they voted with their feet. And these were sophisticated purchasers. That's the thing that gets lost. I mean, every blue plan is a sophisticated purchaser. They understand the market. Everyone uses these 3 or 4 or 5 really smart consultants. So, I get the lack of transparency and the concerns. I think the lack of transparency is far less because the contractual relationships are such that you have to be transparent with your customers. But, at the end of the day, some very, people don't like what saving money is great, right? But remember, saving money from someone is costing someone else income and revenue, and naturally there's a tension there.
Well, PBMs do have their various sources of animosity, let's say
Oh,
that.
yes, they do. That's for sure.
Being a middleman is in the middle.
Exactly.
But so CVS bought Caremark. So the PBMs are typically own pharmacies, or pharmacies own them. And then CVS took Caremark and, so I guess, basically sold it to Aetna. Is that what
No,
happened?
no, no. What happened was CVS. So CVS was the pharmacy, and then CVS bought Caremark to create CVS Caremark. And then CVS changed the name to CVS Health when we stopped selling tobacco in 2014. And then CVS Health bought Aetna to make a
I see.
combined entity. And so what you've seen in this industry is it's like everything is cyclical. So a lot of the original PBMs in the 1990s, 80s, and 90s were owned by health insurers. They spun them out. Then they were in the 90s were bought by pharmaceutical companies,
Mhm.
right? And then in the 2000s they spun them out, and then they started inter PBM mergers, and so you ended up with basically three large ones. And United bought one that's now called Optum. CVS, in the other way, bought Aetna, and then Cigna, which is a large health insurer, bought Express Scripts. So now you're kind of back to the early 1990s, where the late 80s, early 90s, where the insurance companies and the PBMs are under one roof.
Yeah.
And if I was going to make a bet, I would bet that cycles go like cycles for a reason, and we'll see another cycle.
Yeah, I mean, really what you described is different approaches to vertical integration. Who wants to
That's right.
vertically integrate, right? Okay, so PBMs are there, they're going to continue to be there, and they play a useful role that there may be better ways to do it, but this is the way we're doing it in America. I want to finish now, Alan, with your interest in n-Lorem and 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 why I think n-Lorem and both the managed care and insurers should be a natural match, and in that we're we're giving drugs away for free. You don't get better than that. And for every patient who benefits, the reduction in healthcare cost is extraordinary, or potentially extraordinary. And so why is it so hard for n-Lorem to get to insurers to talk about all this?
So it's a good question, Stan. And as you know, we've been talking for about a year, so I've learned a lot. As you know, you kindly invited me to join the board, so I'll learn a lot more. So I will preface my answer by saying it's still a little bit of an answer of naivete. But I will tell you that my reasons for wanting to join and help is I really thrive and enjoy solving hard problems with people I like to work with. And I think the problem of n-Lorem is a combination of small patient populations. So it's below the radar screen of most plans and employers. Even though you're not making a profit, the actual cost of goods for the drug is relatively high. And your incredibly clever approach to getting the FDA to allow you to do kind of N of one trials also completely gets in the way or allows every payer to exclude coverage. And so all of those conspire to make it very difficult. Then you have a very good point, which is when you treat people, you lower the overall cost of care for these very, very sick people. So then you get into another problem, which is how long, and this is a little bit of a problem of the US healthcare system, is how long does anyone stay with any one payer, right?
And how long does the CEO last, and what is his real timeline?
And so, if in an average insured population, the churn is 30 or 40%, and if the average, if you think about some employers I know of have 50 and 60% turnover, and even a a Fortune 50 employer of choice is going to have some amount of turnover, people retiring, people going to another job.
Mhm.
It gets, all of that churn, whether it's 5%, 10%, or 50%, it makes the return on investment harder and harder and harder. So it really, what I'm super excited to learn with you is, how do we tell a different story? How do we create a different environment, whether it's expectations or regulatory, or how do we work with the FDA? Like, there are solutions here. Some are really hard and require, changing the way the FDA works or asking, and some might be easier, which are, create a different sort of product that's, relatively inexpensive, that provides sort of coverage for these really sick people. And then, and then there's other business models we've talked about, which is, when it goes from an N of 1 to an N of 100 or 200, how do we manage that? And does that create a funding mechanism where we can, there's all sorts of interesting things. The short answer is, I don't know the answer. It's hard. I really believe I really believe the right thing to do is to figure out how to provide coverage for people. If we're going to live with our current system, we have to figure out how to ensure that within our current system, people who require therapy, when there is a proven therapy that exists, should have access to it.
Sure.
And, we can talk a lot about there's some interesting ideas we can talk about how do we manage the price of those therapies, and what's a reasonable price. Do we use ICER type methods? Do we do international benchmarking? There are ways short of outright price controls to say, to ensure that all actors are acting reasonably and in an aligned fashion. I mean, it's a little bit of game theory. It's a little bit of, so I think that's where we have to think about it. And the idea that there's that the free market, and I'm a free market capitalist, but the idea that the free market it can fix every problem. We all know that there are market failures, right? That's why there's something called the tragedy of the commons, described like hundreds of years ago. So not everything is amenable to a market solution. The question becomes, is how do we build a solution that's inside of a market mechanism so that you don't lose all of the market signaling, but you're able to constrain some of the challenges.
Well, you and I are, again, thinking along the same lines. And I think the message I would give is that, first of all, we didn't know nano-rare mutations existed until the technology made it possible. We don't know, we know almost nothing about nano-rare patients. We're learning rapidly, but we're at the beginning of this process of finding a solution. And n-Lorem is at the front of that. And there are many, many options that lie in front of us that we need to explore. We need all the good brains that we can to help us explore that. And your addition with your experience just amplifies our ability to get there and find a solution that is financeable and humane.
Well, I'm certainly going to help try.
Yeah, well, good. Well, listen, this has been a fascinating interview, and you and I'm sure will have many, many long conversations about this, but we probably just overwhelmed our listeners. But I think I would just end by saying that this conversation that we just had is a truly fundamental conversation about the future and how we make a future that's better for health and patients than worse, because I think that's the option that's lying in front of us. It could get worse.
Oh yeah, no, I think that's absolutely true. So I think that's a good way to end it.
Okay. Well, thanks so much, Alan, and I'll let you get off to running your new company.
My pleasure, Sam. Looking forward to talking to you some more.
Thanks.
n-Lorem is a nonprofit committed to discovering and providing personalized experimental treatments for free, for life, to patients with genetic diseases that affect 1 to 30 patients worldwide, referred to by n-Lorem as nano-rare. Many of these patients progress and die without ever achieving a diagnosis. This is where n-Lorem comes in. They do the impossible by providing hope, and for those that they can help, free lifetime treatment. For more information about n-Lorem or today's episode, visit n-Lorem.org. Any questions can be sent into podcast@n-Lorem.org. Search n-Lorem on Twitter, Instagram, YouTube, LinkedIn, and Facebook to connect with us. This video is hosted by Dr. Stan Crook and produced with the help of the following professionals. Thank you for watching.